Mada, which university that Mary Jo and I have been associated with for almost 5 years now.
22.
And he was called away from his position, first a vice minister of Ministry of Health, and then for a period of time was acting director of this Ministry of Health. Right, of the Ministry of Health. And we don't see him as often in Jakarta, but still an active scholar. He is currently the Director General for Courses in the Ministry of Science, Technology, and Higher Education. He's especially important for those Indonesians who come to the United States on scholarship because he's been a big supporter of Indonesians coming to good programs in the United States. So he said this morning, for instance, with Indonesian students at IT. That's only a part of who I think we think of Ghufron. So that when I asked, would he come and talk to us about the national health insurance? Because personally, I believe, have watched over these years, as Mary Jo and I have watched Indonesia, the development of medical insurance is something that people dreamed about for a long time. Ali can tell his own story about his early years of in economics and health financing. The time he was young, he was really a pioneer. He was a pioneer in thinking about models national health insurance for Indonesia. He was a pioneer in really leading the implementation of national health insurance in Indonesia. When I asked him and said that there would be here also from bioethics that all know, and when we had our colleagues from bioethics in Indonesia recently, we had a whole session talking about the ethical issues. And for instance, someone can't get the proper insurance. Should the hospital still treat them? Blah, blah, blah. There's always these kinds of problems in the implementation and the ethical issues that arise. This morning, I was telling him, Mary and I were at a thesis at Harvard that was about, quote, stateless people in Thailand, up on the border with Myanmar, used to be able to get health insurance directly, but now find it very difficult. Health care. Because they could not now are not citizens, they suddenly not have access to care that they used to. So that there are always these kinds of ethical issues that arise both in everyday clinical practice, but in health policy, and there's not enough money to what everyone wants to do. So I thought it would be a terrific opportunity for those of us from social medicine, and I'm welcoming those from public health, those from the master's program, etc., to think about the development, the history and the development of national health insurance in Indonesia, which I think has been an enormous step forward with complications. So an honor to us that you decided to make 1 year. I know it's a short visit here, and that you decided to join us at Harvard. And welcome. Dan silahkan.
Thank you much, Prof. Fan, Prof. Marija, and all the distinguished professors, distinguished guests. So it is an honor that I am invited to deliver a speech on here on Indonesia's new national health insurance program. We progress ethical challenges in implementation and practice. So, as mentioned by Byron, that involved in developing this health insurance or social health insurance, or we call it national health insurance, or we call it universal health coverage. So those who do not know Indonesia, here Indonesia is Asian country. So usually know rather than Indonesia. When I first time visited US, what my colleague asked me, so where I'm from Indonesia. So where is Indonesia inside? What part of Indonesia is? So this happened. East Timor, some countries in the ASEAN. Actually, one of the countries so commitment helping the world. For example, President of Republic of Indonesia, together with Prime Minister of UK and President of Liberia, the co-chair at that time was assigned by United Nations to draft of post-MDGs agenda. So 3% is quite time, and then casting there were 12 goals, and then by United Nations, then it was improved to be 17 goals. And so, and Indonesia, member of Foreign Policy and Global Health Initiative country, at the time also together with this countries to the UN Universal Health Coverage Resolution draft. I was because I represented from Indonesia. And then this year, so with the 70th anniversary in World Day 2018, the theme was chosen as universal health coverage. Everyone, everywhere. It means that everyone can access essential quality health services without suffering financial hardship. And that of the world lack of access to essential health services, and here 100 million people are being pushed into extreme poverty because they must pay for health expenses out of their own pocket. This was on the report by the WHO and World Bank in the year 2017. So we had to shift the world, the commitment to achieve sustainable development goals, at least in my opinion, goal and number 4, good and well-being and co-education. So if we like to, bridge quality of competitive human resources with integrity, it's not only providing high quality of education, but also the globe providing access of high quality of healthcare with affordable costs to all citizens, we call it coverage, to at least the target is 1 billion more people to benefit from universal coverage by the year 2023 if we are to meet the Sustainable Development Goals by the year 2020. Then in Indonesia, now we would like, in the process of higher education reform, the university is not only agent of education, agent of research, but also as agent of cultural development, transferring knowledge, technology, and agent of economic development. So now how to, between the university and also the industry. So research should be linkage. So in Indonesia now, the way to measure the university is good or not is new main indicators of this one. So it's our strategic planning in 2015 to 2019. So now back to the healthcare information. So how is Indonesia, as to know the figure, compared to UK and US? GDP per capita, it is very far, with 3.9. G2, USA, 56. Health, only 2.8%, or 27 billion US dollars. UK 200, and US is huge number, 1,400 billion. Budget for health, 5.4, 50 and 980 billion. And then hospital per bed here, doctors, then per 1K, 2, UK is around 9.5.4. And you know the mortality rate, Indonesia is only 46, US 70 and UK 71. But the development, Indonesia already achieved 70 years in the 2014-2015, as 79. And if you look here, of course, you spend a lot of money here. And you can say that commitment of Indonesia is a little bit low because only allocated money, 2.8% of the GDP. But to look the result, is, you know, spend more than 10 times, but we get, you know, the life expectancy, of course, is different. But I think, you know, opinion, it is more efficient.
More than 100 times.
Yeah. Yeah. Not 10 times, 100 times.
But by the time you become over 70, you're glad that it's 70, not 70.
Right, yeah. Okay. Here is the Indonesian figure. Not stop because it is too detailed. What the Indonesian healthcare system trying to reform? You know, we already reform healthcare financing reform and healthcare delivery system reform. So first, briefly, everything is carried out by government. But after we establishing a carrier, national health insurance carrier, or we call it BPJS Kesehatan, the task was divided, task by government, which is setting a regulation and then control the quality, and also handling health services in very remote areas. And for corrective services, it's mostly made and done by BPJS Kesehatan. So the commission before and after reformation. So before reformation, universal coverage, many poor in Indonesia have to have access to healthcare. And there was a poem in Indonesia and a book entitled "The Poor Return to Falsehood." But now, when we already reform using universal coverage scheme, now the poor is false is forbidden to pay. And health is not important issue for public at the time, around 10 years ago. If your election, thing like that, it is not an issue. But now it's very important issue. Doctor, hospital, they can set their own tariff, very high tariff. But now tariff is set BPJS, but it's too low. So a little bit not satisfied, and for the hospital because a little bit too low, and not the referral system of healthcare. So now structured like here HMO, that then not effective healthcare system, here cost effective healthcare system. So it's the situation of universal coverage in Indonesia a decade ago, so not long time ago. Population coverage is only 11%, mostly are employees, civil servants. Financiation, heavy out of pocket, 30%. And people in rural areas, my neighbor also, if got sick, they can sell, the billings like or anything for sometimes. some, offered me. They thought that I have money. Can you in my house because I have paid the hospital. It was around 10 years ago. And again, that was forbidden to speak. This is the history actually of universal suffrage in Indonesia and the milestone. So in '69, it was first time citizen benefit scheme was introduced. After the 1970s, health card, early 1990s, managed care system was introduced because at the time I was also sent to US, especially to LA, to little bit study of managed care. So we started SMO, PS, things like that. And it was developed in Indonesia. Then 1992, Social Security for formal sector employees, some suspect. After crisis, 1998, Social Safety Net Program for Health was implemented. And then this is in October 2004, Indonesia enacted the National Social Security System Law. But the problem is, sometimes they cannot be implemented. But 2005, the health insurance for the poor offered 6.0 billion program, and people program was introduced, and asked by the minister, that time minister from alumni from Gadjah Mada, a consultant how to develop this. And government health insurance initiative grew this time, and we are still confused at the time. So what type of system? It's like Medicaid here, or so census, it's not really decentralized, but integrated decentralized health insurance system. And we went to the constitutional court. In 2008, implementing prospective provider payment system, DRT and capitation. DRT was first developed in US, especially the university. In 2010, we have jumper health insurance for the delivery. So anyone who delivered, it was covered and paid the government. So some rural, they are very happy, so they just pregnant because paid by the government. Then 2011, carrier. We have really like in US many health plans, many health insurance, but in here, all carrier should be one. This BPS, actually two BPS for and BPS for health. And the real implementation in the year 2014, and complete coverage was used. So we would like to see one. First, government, and then health insurance members, or health insurance carrier, and health facility. Second, the responsibility to complete and renew necessary regulation. And within 1 year at that time, we will time to follow this regulation, and not easy. Monitoring evaluation, establishing health technology assessment, whether new drug should be listed in the formulary or not. Developing health infrastructure, creating and producing human resources. Improve data for the poor. It is easy to get which is the poor, which is rich. It's not easy. Allocate necessary budget for the poor. So we make roadmap that in 2019, all should be covered. Now the membership, explaining of the membership, again, the whole population should be covered in the year 2019. Now we reach 196 people covered, so it is around 77%. We establish like centers, see satisfaction level, waiting time should be less than 30 minutes. So compared to non-member, what the call payment, and so forth. So we know in WHO, the type of indicator of universal health coverage achievement. So we call it the breadth who is inserted, and also the test, which benefits are covered, and the proportion of the cost is covered. So if can we the video? So we can check it from WHO. WHO has the definition of universal health coverage. The thing, again, this year, the theme of the first three of the WHO is yang satunya lagi. It's coverage. Okay, universal health coverage actually is the powerful public health tool, and we hope everyone should have access to healthcare without facing financial hardship. Oh.
I'm connecting again.
Nggak apa-apa, yaudah.
It's down
Ini
there.
aja. Video
What
aja.
is that one down at the bottom?
Yang ini aja. Oke, awal. Okay, so let's show this problem.
Click was no, it doesn't play. It looks like when something was disconnected, it doesn't.
Can we click? Oh, no.
No.
It's working, right? So when you talk about coverage, a card, and there's another thing to have something behind it.
Right.
So you have 77% of the people have
Yes.
cards, right?
Yes.
Behind it. You do enough money?
Yeah, of course, it's been enough money. But until now, the government is already deficit. So deficit 9.7 billion rupiah. So we should be, convert to US dollar. But this use money, the coverage is here. Not only the most powerful single concept that public health has to offer, but also in Indonesia, I think it is according to the law, institution. And I think using universal health coverage approach, it gives us, every citizen of Indonesia will have high quality, equity, and also access to healthcare. Okay, can we check? So the aim actually for the universal health coverage in Indonesia, then I think.
Too many people?
Okay.
Coverage is the most powerful concept that public health has to offer, because it's the mechanism to implement the right to health, implement equity. Now, universal health coverage is, something that needs to be homegrown. What do I mean by that? It was the political leaders, citizens of a country, decide on how to start and then how to progress. There's no one-size-fits-all model. It must take into account their, historical development, the health system capacity, and their ability in terms of the speed and the scope of coverage to move over time. WHO can do several things. Number one, we facilitate and convene countries to come together so that can share best practices and experience. The second thing we can do is provide tools for governments to do the proper analysis so that they can design their own system and their own model. The third we can do is provide a framework for monitoring progress over time. It is important for political leaders, the citizens of the country, as well as for civil society to understand and appreciate what has been, achieved over time, or what gaps, so that, actions can be taken to address those gaps, and overall to the health of the people.
Presentation. So those are interested can, see here in universal coverage in WHO web. Yeah, so the concept of WHO. Next slide. So, finish and also financing protection. Compared in the ASEAN countries, it's our position. Malaysia, because tax-based system, 110, and protection is around 40%. So, means that average of Malaysian, they still have to pay around 60%. Thailand, 90%, and the health service coverage, number of population, so like in the WHO, concept. In Indonesia, at the time it was, published in Lancet, 60% and now 77%. So financial protection is around 30%. It means the costing is around, so 70% is protected. Vietnam, Laos, and Cambodia. So here, you see in the globe, United Nations Development Program, previously there is no universal coverage, but it looks very fast. In the United States in 1969, then here, US is around here. France, South Korea also, very fast. And if we see the number of population and the GDP per person, life expectancy. China, Indonesia, here, then they're now around 70. India, China here. So the GDP person huge. Here it's quite different, and maybe in the future this will be almost similar. So that even actually GDP per person, there is ability to achieve universal coverage. Not rich people, but the life expectancy versus expenditure over time, the US compared to developed countries. So here, if we look the comparison between open healthcare and private care. So I think Indonesia actually compared to US sharing many things. We are, the population almost similar. It's, around 260. I think US also 200, almost 300. But we saw Obama, our president, because when it's in his childhood in Jakarta, so after he sent it to US to develop Obama healthcare, and we follow it. Yeah, to develop. We call it in Indonesia JKN, KIS or BPJS. Now American healthcare here, and plan and coverage is positive, but we can see it. Every effort, but how much is not there. This is a problem. Obamacare, essential benefits, but some care depend on the needs, especially young. They can choose. Intended to cover all. Yeah, that in the year 2019, all will be covered. I think also like that. There is Medicaid extension, but here there is no Medicaid extension. In compulsory individual mandate, the federal penalty, here shown now. The exit condition, actually this has to be included, to be included, but more. And US farm care, actually has to be included, but smaller coverage. What volume depend on its location, here similar, relatively similar, selective coverage, especially working age. Insurer centralized, not for profit. Obama decentralized, especially for Medicaid. Federal, it can Medicaid expansion if it can put more money. Here, mostly depend on the state. So federal not quite intervene. Public primary healthcare, referral hospital, and it is SMO like. But here, SMO and PPO, this depend on type of plan. And capitation on primary care and DRT for hospital. You develop DRT, but not all facilities using DRT in US. Some fee for service and value-based payment. Preventive care, more preventive, less than the focus. But I don't know for the abortion. Yeah, maybe covered. Then health insurance carrier in Indonesia. Problem is not only the membership but also the financial difficulties. We deficit. Health facilities, we have system, number of primary care and private clinics. We say and the problem is here. Health providers felt that the payment is lower than the market price. This is the problem. And facilities, number of facilities already contracted, and the number of referral hospitals. So this like SMO, so should be referred. They will be directed to specialist tertiary hospital. This package, Indonesian. Pre-admission is covered. There is no. If you already suffer from heart disease, okay, you can be included. The result, catastrophic diseases load is quite here. So consume huge amount of money. This is the catastrophic disease again. Thus, we are facing ethical challenges. This actually sustainability of the scheme. Marijo already mentioned, deficit is increasing. Every year, we increase the deficit and increasing and increasing. I do not know up to when, but because now is the almost election time, presidential election, it then will increase the premium. This will be very sensitive to the citizen. Payment mechanism and the tariffs, they will the price. Socialization, employment is still limited. Membership, especially from the rich and informal sector, especially the farmers, is very difficult to register to this system. Quality and quality of healthcare infrastructure, especially in remote areas. Membership, complaint resolution, management, human resources, and the class of the role, task, and responsibility of the main stakeholders or institutions such as Ministry of Health, National Social Security Board, Social Security, and also the local. So, for example, Medicaid, the state is very strong, but in Indonesia, local government or state is very for this system. They just as observer, so all doing nothing. For the component, there are at least two problem challenge, ethical challenges. First classification, poor and poor. So, to classify. So according to Central Bureau of Statistics, the poor is only 11.5% or 27 million people. But because differentiate is very difficult whether, near poor or near rich, what is the difference? They covered 92.3 million. So this is paid by the government.
The people in the border, they're like so classes, yesterday above the line and today below the line.
It's fragile. I mean,
Yeah.
it's fragile, if you're really low.
Yes.
It's like there. It's not just poor rich. It's that range.
So this is very difficult then. Is, for example, if they are not classified, in fact they have rights. Or some of the stateless persons do not have, then this again a problem. So actually, but they are not actually cannot show the his right. So very difficult here. Especially from the high salary employees, is only paying maximum 2 times of minimum of taxable income. So the rich is they only pay little, limited of money. This is not quite fair because they pay little and they pay of the same amount of money.
Mm-hmm.
The concept of solidarity that the rich will pay more than the poor, then concept of redistribution has to be problem here. Solidarity is there but not quite strong. Yeah. They only pay 2 times of the non-taxable minimum income.
There may be truckers.
This is ethical challenges for providing services around. Actually, not only Indonesia, U.S. estimate 10% of our total health expenditure is related to fraud. I give it the textbook. And in more, but now the Anti-Corruption Committee is trying to enter to the health facilities. And of course, this is one of the, what you call the region was cut by the Anti-Corruption Committee because some of the money should be, given to the health centers, and he took some now to jail. But sometimes, the hospital said it's full. In fact, it is full because the payment the hospital is a bit lower than the market price, so it is full. And cases, especially private hospital, ask the financial guarantee. So this one, because the price also the guarantee, financial guarantee, then they do not provide services. But it is rare, but it occurs. And one of the baby died because of this health guarantee, but not many. Another procedure, operation, because tariff is higher. So a cesarean section, the normal delivery now using. Equity area where they pay basically the same premium. Infrastructure is availability is low. So here we can see it, the number of cesarean section is increasing. This is a factor. Yeah. When from this is around 40, 45 up to 57% on in the month. Yeah, less than a year. Less than a year. November. So anything. Because cesarean section is more expensive, so the hospital get more money compared to the normal delivery by normal
imagine. That must be that looks maybe the explanation behind the U.S. one. An incredible increase in C-sections over the last number of years.
Yeah.
The exact rate, but it's really right.
Yeah. Too high. Yeah.
Too high.
Yeah. So this is increasing. Maybe here, but we do not know. The doctors to the Mada, if you use cesarean section, you look like the virgin.
Oh no.
So this is a critical success factor for actually. If you can say success, but success or not success, then we can see it. Now the problem is again, we are, have challenges. Many challenges, for example, like the deficit, political commitment, we have a critical mass of experts and stakeholders in the national health insurance. We have few people actually who are experts in this, system. Capacity and system design implementation, learning experience, running different skills of the past, training for enhancing health structures, especially in remote areas, resources for health and health insurance, education, advocacy, and awareness of various stakeholders. This is a little bit problem. Solution is that it is our ability to shape better world by implementing global commitment on sustainable development goals, especially goal number 3 and number 4 at least. So good well-being. So training and implementing universal health coverage is approaching to achieve this goal. So everyone should have access to quality health without facing financial hardship. And as we know that there is no one size fits for all for coverage, therefore it depends on the country itself. It depends on the philosophy, commitment, resources, capacity, and implementation of the country. U.S. I think with higher resources, it is easier to achieve universal coverage from Indonesia. However, lower resources, again, and countries like Indonesia should also be able to achieve universal coverage. Both in and poor countries, universal coverage will bring huge benefits actually, not for health but also the economic, situation. And many challenges in implementing and practicing the universal coverage program in Indonesia, including ethical challenges. Of government, for example, that the government has to be, more of this and developing appropriate regulation and health insurance care, BPJS, especially the deficit. So it is our big challenge and deficit in this. But unfortunately, the director of BPJS, director of health insurance carrier, it was said deficit. He always said mismatch. But what is difference between mismatch and deficit?
So, interesting.
Healthcare facilities, members of citizens of the country, challenges. Appropriate strategic measures should be developed to solve and anticipate these challenges. That is all, and thank you very much.
So if we have time for questions and discussion of this, I'd just like to ask a couple of questions to begin with, Ghufron. So in a rather technical talk, which is very helpful. Just in general, if you look at the last 5 years, how do you feel? Like you have these kinds of conversations, less technical conversations. How do you feel that Indonesia is doing? Are you feeling quite positive? Oh, as you said, it's become something that no politician in Indonesia could ever run against Gadjah. Right. Would be impossible. But how are you all feeling as to how this is going?
Of course, happy, and it was,
Right.
But at the same time, now I'm also worried, especially for the deficit. And if now we have to wait the time, if too long, then there will be problem. And I'm worried if the problem cannot be solved because deep and too far. But if now and can tackle the problem, and especially we know what is the problem, how to problem. But again, problems to realize the real problem.
Just one specific question. You know, Indonesia is a country that is so hard to develop a complete manual private healthcare system, the puskesmas system that was a tremendously important developing. Was focused almost exclusively on middle and child healthcare. And I say there are some parts of the world in which just developing primary healthcare is important, but in parts of Southeast Asia, primary healthcare was developed now and has been very successful in reducing both mortality and even maternal mortality. But now the private healthcare system is being asked to do tests it never did before, to be able to help, to deal with tuberculosis, to heart disease, to do real triage, etc. Often with physicians who have a whole healthcare system that was not designed primarily to do that kind of work. We see that there's now a tremendous challenge in building the competence at primary healthcare level to serve this whole system.
It is really challenging because now wisdom is really rely on the primary healthcare. In fact, the primary healthcare was not designed to solve all problems.
Right.
Okay. Again, like the psychiatric diseases should be solved in the primary healthcare. In Indonesia now, the doctor or primary care physician has to able to solve 155 diagnoses. And in the medical school, not catching of that,
right,
because that time it was not, again, designed, it should be only for promotion, prevention, and some mild diseases. But again, I think it's a challenge. And now we are developing primary healthcare curriculum and primary healthcare study program to pick up with the development in the task of primary healthcare centers.
I think a big challenge. I used to go to the primary health care centers years ago. The number of patients seen per day was pretty low, although still, often doctors would only spend 5 to 10 minutes with a patient. The healthcare center I've gone to in the last year say their numbers of patients have doubled or tripled in 5 years because to enter the system, you have to enter at the primary healthcare level. So I think it's just a very big challenge to build up the primary healthcare site.
But again, because primary care now is the responsibility of the local government. Local government are not really aware of the task. So the local government, at least has to get at least 10% of the local government budget. But unfortunately, not all the local government allocated this amount of money for health sectors. This, again, is another challenge.
So is it possible that someone could run for office against this system? I don't think it's a wonderful system, but when people hit the financial deficit, I would like to hear you speak a bit about how you think mental health care and add a little bit to that being covered by this as well. Or not, you see it working well?
Yeah, I think by regulation, by law, because developing comprehensive coverage, so psychiatric diseases of psychiatric patients actually are covered. In reality, there is a big problem because this is not placed in the primary healthcare, but in the psychiatric hospital. But psychiatric hospitals are limited. So in the practice, this is sometimes a little bit problem. So we call it not effective coverage. Some area, for example, like Jogja, the social affairs, they tackle problem. But because the background is not medical science, sometimes it's difficult for them.
So let's open for questions. So there are people here who are from the School of Public Health who are very involved in this. So first, yes.
Thank you. My name is Nani. I only have two questions for Professor Ghufron. Thank you for the presentation. It is very enlightening to me. The one is about behavioral health treatment. One of the things that I learned when I came here, which I think is not yet existent in Indonesia, is that here most, if not all, insurance plans cover behavioral health services like smoking cessation services, weight reduction, and so on, which I think is very important because you mentioned earlier that we in the place in the deficit issue, and we know that this and diseases and death causing diseases most likely are chronic diseases which are related to behavioral health issues. Is Indonesia going that way?
It is not done by BPJS or health insurance, but actually by Ministry of Health and district office. But Ministry of Health and district office have limited. Now, for example, like trying to register of healthy behavior. So if people are smokers and then they are following and trying to change the behavior. But again, that is not the health insurance scheme, but it is by Ministry of Health and the district health office.
Okay.
Thank you so much for the presentation. I have several questions, particularly in regards to the deficit. First question is more on the premium. Before the BPJS was implemented in 2015, even from the beginning, people have already calculated the premium is about $5 per person, and then it's always being the power, always being bargained by the Ministry of Finance. I think my question is, can you show me what was the dynamic between the Ministry of Health and the Ministry of Finance trying to find this ground? Because as you see now, it's working with the number of payments is too low. That's the first question. The second question is, when you were doing the earlier about some health technology assessment, and that's to look at new drugs or new interventions that's going to be implemented in Indonesia. What are the current interventions that are out there that's already being implemented in Indonesia that for sure it's not cost effective? For example, maybe something like a very terminal treatment for renal failure or terminal treatment for heart disease that are very resource draining that could have been allocated elsewhere. Has there been analysis on the toxicology assessment side to evaluate those already implemented? Thank you.
For the first question, how is dynamic relationship between Ministry of Health and Ministry of Finance? And it is my personal experience. Because when calculated the premium is around $4 per month per person, And the Minister of Finance said, no, it is only 1.5. Is that. And I argued long, and we were, what you call it, as the technical argumentation. And we could not answer. He said, you cannot increase, and many doctors will protest. It is not my responsibility, but your responsibility. And so when you started to be the member of legislative body, it's arguing like that. So finally, actually, then stop. We cannot meet, cannot be agreement. So this the non-agreed. He's the minister, and we also said to the minister, and then we have strategy, which is, or if I can say, my and some of my colleagues, where the president, SY, SPA, his Ministry of Health, many newspaper, many journalists will come. So we will already think of premium rate. Minister of Finance say 1.5, and we said here 2 and 3.5 and dollar and 5 something like that. So then in the session with the president, which one you choose among these? Because Minister of Finance has only 1.5, we do not include in the choices. So there's only 2, then 3, 5, and 5. So and then choose the one, which is 2.5 actually, and then there is 2.2. The journalist already captured analysis in the national level. And then, okay, it's already announced by president, so they cannot go back. And hence, already president said 2.2. Yeah, on 22,000 rupiah, like that. Okay, the Minister of Finance always see that health is spending. Minister of Health always see that health is investment. So not do it always. WHO and World Bank also have the same problem. And then in Geneva, invite all Minister of Health from all the globe. So World Bank invited Minister of Finance. All Minister of Health came, attend invitation, and no one from the Minister of Finance came to that meeting. So this is not easy. So, one question? Yeah, technology assessment is very important, and now we are developing. Also, we still trying to, develop the human resources experts and the health technology assessment. Now we are developing also the course health technology assessment. But for the existing, effective procedures or techniques, they, only limited. So now we have started those new technology or new drug which is with the system. But if already entered to the system, I think we will do nothing. I see in the future.
I mean, he's a point about end-of-life care. If you can solve the issue of how much money is spent at the end of life, then you have done something no other healthcare system has ever solved.
My question is,
Right.
if my life should be spent more, we can calculate. It is not a question. So up to how much money we can go, how much we have to spend. So actually by law and by the system, how much to spend. But problem is, if we spend that as your question, this is the ethical challenge. Actually, we can allocate for other mild diseases and recover for many people. Increasing one life of the person. The question again, whose life is it? If it's of the president, or we have to pay how much money? It is not easy. Yeah.
Local government and institute health. So how do you coordinate and improve the supply side? That's my first question. How do you
Yes.
local government and
First, my answer is because I'm not in the Minister of Health anymore. So actually, the question should be addressed to the Minister of Health, not myself. No, I move for it to the Minister of Higher Education.
my second question actually the poverty data and the figures were I get to use the first class and I looked at that very intensively how people were how they enter and how people like this come or not. And the system is old in the sense that the system is old. So people who are in the poverty list is recorded prior to what is actually there. So the mismatch between even the birth there or not. Right. And I don't think people in Indonesia does not have the technology to make the direct poverty assessment.
Right.
Right. So I presume, is it because there is a deficit that you don't cover so many people that you lose period with more? Why is that not? It's never discussed.
No, I think in my opinion, it is in the design, it is not really appropriate. Don't know really the condition whether it is poor or not poor is the government. But system, local government is not involved. Government is only observer. So it should be changed. Science should be changed how to increase the commitment involvement of the government. When report, and now is developing identity card. By using that, actually not so difficult. But the government should be responsible and should be involved in this system. But unfortunately, now local government not. Yeah. Right. Yeah. Yeah. Usually by technology is not so difficult again. I think this is mistake on the design and the commitment. I think.
Yeah. So I think here on one of the slides you showed, there should be 27 million, but there's only 92 million.
Now, in Indonesia, actually, sometimes difficult because almost similar condition. We classify this as a poor. What are criteria? For example, weight of the land of the, for example, should be, every person should be more than 8 meters. So when they have 5, people in one house, should be 5 times 8 should be 40 meters and 40 meters. If less than that, it is one area of the poor. Here, if they have to, have money less than the US dollar per person per month. So people in 100 US dollar per month, one household, it is poor. Something like that. So there are 22 criteria of the poor. But because it is almost difficult to differentiate poor and near poor, or poor and near rich, the government increased up to 92 million people are covered and paid by government.
That seems reasonable. Yeah.
My opinion, it should be add more.
Yeah.
Problem is whether the money is there or not.
Right.
But actually, the money is there, especially when we are to the tobacco company. The tobacco company in Indonesia, our richest number 1, number 2 is the person who has a company for cigarettes.
Right. Yeah.
This is a lot by my other intervention. What percentage of people you're talking about? People of big tobacco companies, but when you put in the well-to-do middle class, how many Indonesians nowadays are? We see enormous, very modern, selling stuff from everywhere, right? And so the market change is the people who have money, a lot of money.
Right.
Just to kind of break down as sort of an assessment of what percentage of people are, say, in the top 10% and then the middle, that are people who, have cars, not just motorcycles, go on vacations and all this other stuff, have enough money to spend maybe $20 a month for health care, or $100 a month for health care.
Right. So, of course, just estimate. Yeah.
Yeah.
We can.
Yeah, I mean,
we can see the statistics.
Yeah, much.
Yeah. So, rich, actually around 20% of the population are rich. Around 20%. So they can, make the right to overseas around 20%. So 10 times 260, so it is also a huge number.
Right.
For example, 20 times 250, like 50 million. So 50 million is all similar times of the population of Singapore.
Right. Right. Exactly.
So then around middle is around, so middle income earner, and then 20% is around 30%. And then the middle income and the poor, actually, statistic is only 11.5%, but reality is around 50%.
Right. That's my sense too.
Yeah. This is statistic is depicted with my sense.
Yeah.
But it is real, because why the government then pay for 92 million people?
Right.
They're able to pay.
But why does the government charge only that low amount for the people who can go overseas and buy 4 or 5 cars or whatever?
It's very difficult, and I have also, again, my personal opinion and experience. This time, we are facing with what you call it, association of companies and commercial, commercial association. So the rich and they are very strong. So the rich to pay more, and they know. And the business have very good, power to the government. So this is the problem. Especially, if salary employees of the company should pay huge amount of money, then company will collapse. They say that. So in the government, okay. And like that. So it cannot be determined only Minister of Health, but IC. So Finance, Minister of Enterprises.
Question. Been here for 8 years, so I know a lot about this political system in the U.S. with the Health Act. I don't know what is that Obamacare. So in Indonesia, I just like to know, is there any political parties in Indonesia that their platform is trying to expand this healthcare system, or any other parties on the other side try to reduce the dynamic of political system in Indonesia in terms of health?
Very difficult. Also, the health is instinct for the political parties, political difference, political. But those who really know the reason and how to sell it, it is not quite strong. But I hope that this coming national election and also the local election will be the regional level. Yeah.
For everyone who has an ID card, nationally, they have it. But I don't know other parts of
I think awareness that the health issue is important in election. Increasing, not as long like in US where 50% Republican and the Democrat.
So question back here, yes.
Hey, Dr. Ali, then you from the Philippines and from the Gulf of Mexico.
From Indonesia.
My question is about, I think you mentioned on your presentation that doctors are complaining because professional fees not being adequately covered by the insurance. And the Philippines are encountering this same situation as well. Philadelphia is not able to fully cover for the CF and physician workers. They think they need to charge more. They want to self-police even their own professional fees. Are you negotiating that with like the medical association? Because like it basically opens doors for like let's say under the table, we're seeing that in the Philippines, apart from what PhilHealth is paying for professional fees, doctor in the bedside charges additional fees again because PhilHealth doesn't cover what the doctor thinks is total.
Association now the difference is between health carrier or PhilHealth Corporation in Philippines, Association of Medical Association and Hospital Association. So and me, but of the government also there. So some of deadlock because you cannot negotiate properly. So then government decided. But it is, of course, the hospital association and medical association is loose in situation. So they want, but again they can't because again it's already deficit. Yep. So they just do not want to pay more. So no, the medical association just too difficult. They need to write the complaint. So all complaints write down by the Indonesian Medical Association and send this to the public. So they are really not satisfied and they want change. I can see what they are. Yeah.
I wonder if you could say something about current ministry that you're in, the research, how that interfaces with care, if at all. Right. I mean, if there are research components, first of all, in doing what we call translational medicine, trying to get new therapies widely disseminated, or in the early slides, you had a very interesting slide, which from a Singapore point of view is quite odd. And you had a circle of reform universities, and then there was culture, and there was economic growth. Right. Singapore doesn't have the central circle. It's economic growth. So very interested in the university reform, what's being done in medical schools in order to create a higher quality medical cadre, technology that is distributed rather than just high-end technology. I wonder if that's part of your portfolio.
That is part of my portfolio because now we have shared problems with the Ministry of Health.
Right.
So under the Ministry of Research, Technology and Higher Education, there are 24 teaching hospitals. Where teaching hospital has to, do research and finding new technologies and then tested it and then of course can be developed. I was assigned, now I'm assigned to, as the joint committee between Ministry of Health and Ministry of Research, Technology and Higher Education. So we are developing what we call an academic health system. So after where the medical faculty of School of Medicine have joined together with teaching hospital and local hospital. So they introducing, reform and medical school, for example, interprofessional education approach should produce. Also, they have to, the Ministry of Health target, for example, that each new practitioner has to be able to diagnose 155. Now reform the content of the curriculum and the outcome of the teaching learning in the Faculty of Medicine. Of course, then now not only the curriculum and also the learning outcome, but the way to the process. So after finishing medical school, they have to take now exam. If they finish, to go to internship to across the country, they can choose for 1 year, and then after that, now we opening just started primary care study program. So we continue as the primary care physician to again school for around 2 or 3 years. It is new.
Okay, we'll take 2 more questions. Yes.
From Yogyakarta, Colombia, we have implemented universal health coverage for more than 20 years, and the cost rate is really high. Only what we see is that there is a huge gap between the coverage on paper, which is over 90%, and real access to care. So what is that access to physician salary? And I think this is a door that we open for brain drain of health providers in Indonesia. They're not satisfied with the salary. And also, I would like to know what you have you talked to tackle this issue that the wealthiest part of the population who want to contribute more.
So
The first question really has to do with
Colombia, right?
Colombia. The experience of losing position.
Right, I know. Colombia lucky because they have surrounding countries, so the president can be there. Indonesia has it is important to stay together and agree, although we do not keep. That it is the philosophy of Indonesian life. So to stay at home, if no noising. So if, although they are not satisfied of the payment of the fee as the medical doctor, they will go to US. So far, that can not always be accepted in US. So what I say is, there's no percentage. Of course, now 2% is yes, but not so many, not like China or maybe Colombia, yeah, stuff like that. Indonesia is not problem of the friendly because philosophy of living.
But there's a possibility for second.
So my point is because right now there is not like I think of long term.
Oh yes.
Because our system is very like this for more than 20 years. So the results are really showing now.
Right.
So then goes to the other question. What have you thought about strategy to make the wealthiest part of the population to contribute more?
Okay, I'm thinking, but I'm not doing because my job is not now in that case. But of course, surely we have to go to the regulation that the rich have to pay more. Now, also government are thinking how the tax for tobacco, tax should be for the system. So the system can get more money. But the rich think they have to pay more. But many people in Indonesia, they just little because it is the premium is too low. They pay.
But it's not premium, it's also in taxation.
Yeah, in taxation. But now we have a progressive tax. And suddenly the tax is very, very long and very, strict. If just we have to pay double because the Minister of Finance is very strict just recently because now it's very strict. That's just not long time.
The ability to collect tax in Asia has changed very dramatically.
Now, I think we have to publicly debate that the rich in Indonesia not yet pay appropriately to the ability to pay. So in debate and also in the regulation we have to change.
The issue of sin tax, of course, smoking is not a sin. Last question.
So I want to discuss first that my perspective is from for-profit perspective. So I came from United Health Group. So first one is I want to talk about has discussion to give capacity for BPJS to have commercial activity. To give you perspective about United Health Group, we manage 130 million people in U.S. and our fee is about $200 billion. But $100 itself coming from commercial value that we build on top of our insurance product. Okay. So it's discussion on BPJS because it's like different capability for the countries to provide funding for the BPJS. There's been any discussion to create something that on top of insurance product.
Okay, I think it's an opportunity. Yeah,
That's why he's here.
It is here. But I sense of business in commercial, US is much more compared to Indonesia. So the Indonesia, when trying to develop this system, it is like not for profit. So the winning is not really every opportunity and how they to get money. It is not the way to think. Therefore, when opportunity is there, therefore, if I to and use and this opportunity, we invite you there over there. I think it should like BPJS is not for profit by design. There are many data like United Health can be solved, can be solved and can spend money, but they're not thinking like sure. Actually, there are many opportunities if they know. Unfortunately, maybe they do not know. Second, the fee is there is no profit. They have to serve the people. This is critical thinking.
It's been fascinating,
Not yet.
Not yet.
No. But I think if you can expose and introduce them, maybe will thinking in the future.
Just like one additional comment on half of the is in the ethics of money, the ethics of the hospital, because I think is Sandy still here? There the ethics course that the Harvard bioethics faculty, together with the Gadjah Mada faculty and bioethics center, bioethics and humaniora, gave in January. There was the case that Sandy and Ajib designed, in which the problem of forcing the hospital to lie and distort what they're doing in order to get enough money to cover costs of care and costs of the pharmaceuticals. And actually, the physicians here in this country also talk about having to actually lie about what a diagnosis is in order to get the proper care for their patients. So these really rationalized economic systems that are created for healthcare insurance, universal healthcare insurance, or any kind, are structured so that they punish the institution or punish the practitioner, create people who are not honest and feel guilty about not being honest, and undermine the trust in the institution that the clinician has in the institution, that the clinician has in the scheme, disrupt what's going on between clinician and patient. So there's a very complicated set of problems that at the clinical, that gets started at this higher level that gets played out at the clinical level and can be very disruptive in terms of delivering quality of care. So I hope you're able to solve your financial problem. And also, I just, that the U.S. system is in such a strait that you don't want to replicate this one.
I can give you another statistic. We just had project with payment integrity, right? So in the field of durable medical equipment, we have CMS saying that 45% until 59% improvement rate for CT and oxygen tank in the U.S. 50% is huge number, right? Yeah, it's happened here. Again, the U.S. healthcare system drive by private companies like money.
So I said actually, if in U.S. the fraud is consumed around 10% of the healthcare expenditure in U.S. But I'm sure Indonesia is much more than that.
Yeah.
The problem is to identify that it's not easy because we have someone in medical complexity situation.
but at the same time have to know the financial, movement and, how to track whether it is actually out or up or what.
But if you take into the kinds of examples that were discussed in the dialectic meeting, these issues who would call it because they were, but what we're doing was advocating for their patients. Advocating to get the kind of care that they thought their patients.
This is not fraud. I would say this is the system not being designed with a flexibility for clinicians to practice quality medical care in frame, etc. Rather than making money off of, we know that many cases in which, if equipment is bought, that goes into somebody's pocket. But that's different, it's completely different. So I wouldn't even call that fraud. And I think that when they're calling this Medicare fraud, I think that Medicare fraud is a little bit of this physician stuff. What's happening now is that these physicians aren't being except in terms of their personal sense of personal power, control power, also their sense of their professional ethics. So I think that you need to throw it all together in one bag. It's a different kind of thing. Anyway, great talk. Really loved it. Thank you.
Okay, so very interesting, but very complicated and difficult to have approach to solve the problem, the balance between, the call of the professional as a doctor and also the administration.
Okay, very.
Thank you.
The system is very complicated to make work. Mostly with the benefits.
How did you find out? Are you Indonesian?
Yeah.
Yeah, so you found out from the network.
No problem.
I've been thinking a lot of.
I should be giving you. I'll bring you next time I come. No, that's okay. I'll make sure to give it to the next one. Thank you.
If you don't remember to right. My name is no country. Well, my professional work that I'm doing help with me so much writing in this program.
What do you teach?
That's why I am. Put a lot of energy into it. That's why I'm very cooperative. That's why,
Oh, yeah, right.
They don't have like quickly.
Yes, sure.
Follow up. It's about liquid. Yeah.
So I know I'm doing
Both.
wind from one side to the other from
So I originally went to Singapore to take Apple research.
Oh,
What
But I'm chairman of research.
So we are also on the same track. And now many transnational